The liver is a large vascular sponge where most of the vessels are veins. So if we inject, like in this case, red plastic in the hepatic artery, blue plastic in the portal vein, and yellow plastic in the hepatic veins, and note that the predominant colors are blue and yellow, which reflect the blood flow and the blood volume that is noted in the venous structures of the liver. 80% of liver blood flow is contributed by the portal vein, and the hepatic artery less than 20%, and that's why we see very poorly the red hepatic arteries. We're going to study sequentially the portal vein, the hepatic artery, and the hepatic veins of a normal liver. First, in this diagram, one notes that the major contributors to the blood flow in the portal vein are the superior mesenteric vein and the splenic vein, and that the inferior mesenteric vein terminates in the splenic vein, in the superior mesenteric vein, or at the junction of the splenic and superior mesenteric veins. Please note the position of the coronary vein, which normally drains from the stomach towards the portal vein. Note that the junction of the coronary vein with the portal vein is almost opposite the superior mesenteric vein. This explains why the coronary vein may enlarge and flow reversal will occur in any condition that causes portal hypertension. The flow of blood from the bowel through the superior mesenteric vein will reach the portal vein, and there will be a reversal of flow in the coronary vein, as well as in the short gastric veins that drain into the splenic vein. This explains the pathogenesis of gastric and esophageal varices. This is a diagram of the azygos system. The drainage of the esophageal and gastric veins is primarily towards the azygos system. Note that the azygos vein receives blood from the hemiazygos vein, which also drains partially in the left innominate vein. The distension of the azygos vein is primarily manifested on radiographs of the chest as paraesophageal densities and enlargement of the azygos arch. So at the right tracheobronchial angle, we should look for enlargement of the azygos vein when there is a portosystemic diversion of blood. That is, that blood that normally should go into the liver is diverted towards the stomach and the esophagus, and from there to the azygos system. This is a cadaver study of a normal patient. Note that the portal vein has a uniform distribution. The blood supply to the liver comes primarily from the superior mesenteric vein, which in this case is seen a little bit to the left of the midline, and from a tortuous splenic vein. The liver should always appear larger than the spleen. Note also other tributaries to the portal system from the bowel and from the stomach. Another cadaver study of a normal patient. Note the large liver, the smaller spleen, and the formation of the portal vein from the superior mesenteric vein and the splenic vein. In this case, the splenic vein is short, and the inferior mesenteric vein terminates in the superior mesenteric vein. This is a third cadaver study where one can see the contributions of the splenic vein and superior mesenteric vein to the portal vein, which appears slightly narrowed. Note other tributaries to the portal system, and note that the liver shows a normal distribution of intrahepatic branches of the portal vein, and it appears larger than the spleen. This is a cast corrosion preparation only of the portal veins. Note that the veins of the wall of the gallbladder fill from the injection of the plastic in the portal vein. Note that the right lobe is larger than the left, and note a uniform distribution of vessels throughout the two lobes of the liver. When we inject different colored plastics into branches of the portal vein, we can outline the right and the left lobes. So the right lobe is the white and blue, the left lobe is red. And note the sharp demarcation between the different lobes of the liver. This is a cast corrosion preparation of the right lobe of the liver where plastic was injected in the hepatic artery. Note that the branches of the hepatic artery and the main hepatic artery is smaller in caliber than the portal vein, and this is a reflection of the blood flow that goes into the liver via the hepatic artery. Note the uniform distribution of vessels throughout the right lobe of the liver. This is a cast corrosion preparation of the right lobe of the liver, where red was injected into the artery and blue into the vein. Note that for every branch of the portal vein, we can see a branch of the hepatic artery, and that the arteries are smaller than the accompanying veins. This is a close-up of a segment of the right lobe of the liver, red in the hepatic artery, blue in the portal vein. There is a one-to-one branching pattern with the hepatic artery smaller than the adjacent branch of the portal vein. As we follow the portal vein into the liver, we note the progressive tapering, and we also note the accompanying hepatic artery that eventually terminates with the portal vein at the level of the portal triad, which is the periphery of the liver lobule. On low power magnification, we can follow the yellow plastic, which is seen in the portal vein as well as in the hepatic vein. And we note that in the periphery of the liver lobule, we see also biliary canaliculi, and there are also branches of the hepatic artery. And we see the terminal portion of the portal vein. And the blood then perfuses the liver lobule and departs via the hepatic venule. This is a close-up of a small portal venule in the portal triad. The space surrounding it was digested and consists of connective tissue, the biliary radicals, and the termination of the hepatic artery. And from there on, blood penetrates the liver lobule. Here is another close-up of a portal venule in the portal triad. Blood is distributed throughout the liver lobule, and the liver lobule is perfused by both the portal vein and the hepatic artery, and the small vascular structures next to the liver cords are the liver sinusoids. In this cast corrosion preparation, in orange we see the hepatic veins, and in yellow the portal vein. Note that the portal vein is separated from the territory of the hepatic veins. The only structures that accompany the portal venule is the hepatic artery and biliary radicals in the region of the portal triad. The only structure in the center of the liver lobule is the hepatic venule, the origin of the hepatic venous system. Here is a close-up, high-power magnification of a portal triad where the largest structure with a thin wall represents a portal venule. The cuboidal epithelium of biliary radicals depict the presence of the origin of the biliary tract. Smaller vessels are also seen, which are the termination of the hepatic artery, and amongst these structures are connective tissue and lymphatics. In this low power magnification of a normal liver, we note the liver cords which radiate from the center of the liver lobule, where we see the hepatic venule. Connective tissue surrounds the liver lobule, particularly in the region of the portal triad, where we mentioned before are the terminal branches of the portal vein and of the hepatic artery, and the beginning of the biliary ducts. This is a high power magnification of the center of a liver lobule, where we see the hepatic venule. Note the thin wall of the hepatic venule, and note that it is not surrounded or protected by connective tissue, as we saw in the portal triad. This explains why the distortion of the liver lobular architecture primarily affects not only the sinusoids of the liver lobule, but the hepatic venule. And that is why in cirrhosis with portal hypertension, a major obstructive mechanism is the alterations in the sinusoidal portion of the liver lobule and in the obstruction and compression of the hepatic venules. Here we can see in a cast corrosion the central venule and note that there is a large space between this venule and the periphery of the liver lobule where we see the branches of the portal vein, particularly at the level of the portal triad. Here is a close-up of a right lobe of the liver where we can see in yellow the hepatic veins and the portal veins in blue. Note that the yellow vessels form about a 90-degree angle with adjacent branches of the portal vein. So the branching of the portal vein and the branching of the hepatic veins are in different directions and course. With computed tomography and with magnetic resonance imaging, we can provide a 3D volume rendition of any organ of the human body. And when we study the portal vein and the hepatic veins seen in this in vivo image of the liver, we confirm that difference in the distribution and course of the portal veins and of the hepatic veins. And we can see some hepatic veins crossing branches of the portal vein in a 90-degree angle. In this cadaver study, a catheter was placed in the hepatic segment of the inferior vena cava. It was then ligated above and below. Contrast was injected and it fills the right lobe, the left lobe, and the caudate lobe. Note that here we only see 3 large hepatic vein trunks. In this cadaver study, a large segment of the inferior vena cava was isolated from below the renal veins to the junction of the inferior vena cava with the right atrium. Diluted barium was injected into this segment, and we can see a retrograde flow of the barium into the renal veins and kidneys. We note filling of the azygos system and the perivertebral venous plexus, and we can see that there are several hepatic veins that terminate in the inferior vena cava. This is a diagram showing some of the anatomic variations of the venous drainage of the hepatic vein into the inferior vena cava. Note that in some instances we have 2, 3, 4 or more hepatic veins that drain directly into the inferior vena cava. This is a cast corrosion preparation of the hepatic veins, which were injected in yellow. Note the intervenous anastomosis between the hepatic veins of different segments of the liver.